So the second part of our talk is going to be about the panoramic images. I'm assuming most everybody has a panoramic or a Panorex in their offices. So the panoramic imaging, today we're going to go over recognizing image errors and how to correct them and the correct positioning. So panoramic uses, panoramic means wide views. You examine large areas of the face and jaws. Locates impacted teeth or retained root tips. Used in evaluating trauma, lesions, and diseases of the jaws, and we use it a lot for third molar visualization. Assessing growth and development for pediatric patients as well. And for braces, they'll do it for braces. So knowing your panoramic machine, there's a bunch of different types of panoramic machines. There's specific lines that correlate with the patient positioning. Basic settings and positioning tools are the same on different machines. So your basic positioning of the patient is going to be the same no matter what machine that you're using. So why do you get errors on your Panorex? Improper patient preparation or instruction, forgetting to remove the jewelry, glasses, dentures, partials, or bobby pins. I basically become a human metal detector when the patient walks in the room, kind of give them the overview and make sure they have nothing on. Improper centering or adjustments with the machine. So the proper patient positioning. So when they come in, be sure that the patient takes anything metal around their head or neck off. Even necklaces in the back, the chain around the back of the neck shows up in the mandible. And bobby pins, anything below ear level. If they have them on top of their head, it's fine. And earrings. If we have patients that just pierce their ears, so they're unable to take the earrings out, if they have the ones that are put in with like a wrench or clamps or something at a piercing place, then I don't make them take it off. So make sure they take that all off. Adjust the height of the machine so that it lines up with your patient. You don't want them walking in and stooping down and bumping their head on the machine or trying to stand on their tiptoes. Then you would adjust the height of the machine. So basically there's a red horizontal line. It should be running from the base of the orbital ridge to the middle of the tragus, and that is Frankfurt horizontal. That is ensuring that your patient's chin is not too high or down too low. The mid-sagittal plane parallel to the long axis of the face. So there's a red line that runs vertically. You want it right down the middle of your patient's face. And you want to be sure that the back of the head also, there's the mid-sagittal plane. You want to make sure that that's lined up. Their head isn't just turned like this. The red line can still be going down the center of the face. You want to make sure they look straight in the machine. Otherwise, you'll get rotation on your image. Use a bite block or a chin rest to hold their face or to hold their head in the machine. If you don't have a bite block, you can use cotton rolls. If they're missing their anterior teeth, then you can use some cotton rolls between the back teeth just to keep the arches separated. Adjust the focal trough. I'll go over what the focal trough is. Ensure that the machine will clear the patient's shoulders. So you do kind of a practice spin to make sure that it's not going to hit their back or their shoulders as it spins around. And you instruct your patient to hold still. Tell them it's going to be about 20 seconds or so, and that they should hold their tongue flat against the roof of their mouth for the entire exposure. So common errors in the panoramic images: if you have the chin up too high or chin tipped down too much, the metal objects left on. If you don't have the tongue against the hard palate, it causes burnout on the maxillary arch because there's an air gap above the tongue. So then that air gap gets overexposed, and then you are not able to see the apices of the maxillary teeth. So the tongue, when it's pressed flat against the roof of the mouth, it kind of attenuates some of the x-ray, so you don't get the burnout. Rotation of your patient's head, if you have it rotated left or right, and motion, which causes blurriness. So if your patient swallows during the x-ray, I've had patients start talking in the middle of the x-ray, and then you just say stop, and we'll just restart it again. Or if they have tremors or something, you just do your best with that if they have muscle spasms or tremors. So this is what a diagnostic pan looks like. We have the condyles, We have nice contrast. You can see that the hard palate is flat, and you have a nice slight smile of the arches here, which is when you have your chin in there correctly. You don't have your chin up too high or down too low. No rotation at all. You can see the mandible looks the same width, side to side, and the hyoid is down below the mandible. So I'm just showing you what some panoramic images look like with some errors. This is when there was rotation to the right. So you can see the angle of the mandibular body looks wider here than on this side. And you can see the right side of the teeth here, they're overlapping more than this side is. And then magnification of the right condyle here. You can see that it looks bigger than this one. That's because instead of it looking flat like this, you're looking at it from the side, so it looks thinner. Rotation left. This one is not quite as extreme, but you can see the condyle looks more rounded on this side and more flattened here. And also here, the hyoid, the patient might have been swallowing or moving, so you can see it looks blurry as opposed to this side. So in the beginning of the x-ray, I believe the patient was moving. And you can see more overlap on the teeth on this side, on the left side. Chin too far down. You'll clip off the chin, and you can see the arches look very curved into an over-exaggerated smile. But on this one, the patient's hard palate is flat, but you can hardly see the condyles here, somewhere in there. But I can see this side a little bit better here. As the patient tips their chin down, the condyles come in and tip in like this, and if their chin is up, they splay out to the sides. And then chin up too high, this is one of the most common errors. So you can see the condyles come out on the side here, so they're off of the image. And the other problem with not having your patient's chin correctly aligned is that you want to image the tooth like this. I don't know how to describe it, but you want the long axis of the tooth to be flat on the image. And if the chin is tipped up, they're going to look foreshortened on the image. So you're not getting the true size of the teeth. And this is where the tongue was not in contact with the hard palate. So you see this air gap up above. Here's the dorsum of the tongue and the hard palate, and it looks black up here. So you're not able to visualize the maxillary apices. So slumped position, another thing is making sure that your patient is standing up nice and tall. Otherwise, if they're crouching over here, they have like a hump of their back, and that is what causes this opacity right here. This is from the, not just the spine, but from the soft tissue of the back. This patient had some earrings that were unable to come out, some pretty crazy ones. So you can see, I'll talk a little bit later about this, and Dr. Conlin as well, about ghosting. So it takes your image or the object and portrays it across the image a little bit higher and a little bit blurrier and magnified. So these earrings end up over here. So the patient says, well, it doesn't matter, my earrings are off to the side, but it always ends up in the image and overlapping the anatomy that we want to see. Hyoid over the mandible. So this patient, I think, was moving or swallowing. You can see the hyoid right here. Can mimic pathology, get in the way of the apices of the mandibular teeth here. If the patient is too far back, like back in the machine, away from where the sensor comes in the front, you get widened and magnified anterior teeth. And if the patient is too far forward, their face looks shrunken, so you can't really see the teeth very well. If you forget to put a bite block in or separate the teeth, you'll have overlap of the anterior incisors. If you have a patient with a really big jaw, really big face, you can't fit them on the whole image. What you do is just take your bite block off that you would normally use and just bring the patient a little bit forward into the machine, and separate their teeth with some cotton rolls instead of using the bite tab. And that will cause their head to look a little bit smaller, so you can fit it on the whole image. So steps to a phenomenal panoramic image, just kind of your checklist. Prepare and be aware. Make sure to remove anything metal around the patient's head or neck. Adjust the height. Be sure that the patient's head is at a comfortable level. Nose split in two. Vertical red light should run down the center of the patient's face. Orbit to ear. Horizontal red light should run from the base of the orbit to the ear or the tragus. Right in the bite, be sure the patient's teeth are separated by a bite block and their teeth are in the groove. If patient is edentulous, use plastic chin rest. Align to canine. So this is the focal trough. I thought I had it in here, but maybe I didn't. So the focal trough, you need to make sure that you fix this red line that should be running vertical to the canine, and that kind of adjusts the focal trough to the patient's mouth. Move over the shoulder. Make sure there's enough clearance above their shoulders so it won't hit as it goes around. And ego or no more, make sure that your patient's standing up nice and tall and they're not hunched. And close the gap. Instruct the patient to close their lips. Keep the tongue flat against the roof of the mouth. Sometimes you'll instruct them to swallow and then keep their tongue flat against the roof of the mouth. That works, but sometimes I find patients will be trying to swallow and they don't have any spit, and then they start opening their mouth. It works sometimes, but I just usually just tell them to keep their tongue flat against the roof of their mouth, kind of like a suction cup. So we're going to go over some images and pick out any errors that you might see, just so you can get used to how you're going to correct the image. So this one, any errors in this image? Chin was too low down, yes. Yeah, tongue was not flat against the roof of the mouth. There's burnout in the maxillary teeth. And then also the patient was too close to the machine. So you can see that the face looks smaller than it should be. You can also start to see the spine coming into the image on the sides. This will sometimes happen if you have a really small patient, because there's less body to get into there. So then the spine will actually show up. Doesn't mean that you did anything wrong. But if you can look at the teeth, they just look really small. So you know that you have the patient too far anterior.
Also notice the rotation is magnified on the left. Please
Mm-hmm. Oh yeah. Yeah, it's hard to tell from
the
here.
The ramus is wider on the left, so the head was turned.
Mm-hmm. And this one here, it's hard to tell on this one. I think that there was just a little bit of rotation.
Yeah.
This one here.
Up.
Yep, the chin was up just a little bit too much. And then this right here, you might think that that's some pathology, but that's actually the hyoid overlapping onto the mandible.
Slumps?
Yep, slumped, and the patient's chin was too far down. So you can see that the condyles are starting to get clipped off on the top here. So what you would do is bring your patient's chin back up just a little bit. Yep, an earring, nose piercing. If it's an easy one to take out, I'll have them take it out, but sometimes they can't get their nose rings out, and it's not really getting in too much of the dental anatomy. It'll show up in the sinus, but I just let them leave it in. Eyebrow piercings, that kind of stuff is fine. Can't really see too much else wrong with this. Rotation. So the right mandibular body looks larger than the left.
So where's the ghost of the earring?
That's what I was wondering. Up over there, that blob there.
Yeah. And why isn't there a ghost for the nose ring? It's close enough to the midline. It's not going to send a ghost off. Oh.
This one looks really bad. Patient was too close. Chin position looks okay, maybe just a little bit tipped down. And then again, you can see the hyoid here overlapping the mandible. That's usually the patient might have been too close and their shoulders are up like this. If their shoulders are really tight and up by their ears, that automatically brings the hyoid up. So you just tell them to relax their shoulders after you get them all positioned. Sometimes I just run my fingers on their shoulders, and because sometimes they're nervous and they're standing all tight like that, so you just relax them a little bit. Rotation to the right. Everything else looks pretty decent, except for the hearing aids in there. Not a huge problem. Yeah. Yep, hearing aids.
The head was tipped a little bit too. If you look at the ghost images, so the ghost here, the ghost here, they're offset.
So this
The head
is
was tipped a little bit.
the ghost of the angle of the mandible right here, over on the side here. And then this one is this one here.
Very tipped.
Yeah,
And slumped a little.
yeah. This patient's kind of like this in the machine. I think this was probably the best we could do for this patient. You can't always get a perfect image, but yeah, head is tipped down and to the left. And then the tongue was not flat against the roof of the mouth. Tongue ring, yep. Tongue ring showing up right over that canine. Patient has a pretty big jaw, it looks like. Really dense, thick bone. So this side is a little bit wider. Patient's rotated to the right. So why do you want the tongue pressed to the roof of the mouth? To prevent maxillary burnout. And the patient's chin level. So here's the Frankfurt plane I was talking about. This is the horizontal line that you will adjust to make sure that it's running from the base of the bony orbit to the middle of the tragus. Why do I want my patient upright and not slouching? So you don't get the hump of the back in the image. And what if your patient has really large shoulders? Sometimes you have to sacrifice a little bit of the chin level that you want and bring the chin up just a little bit. Another thing that helps is to have the patient cross their arms and grab the handles crisscross like this. That automatically brings your shoulders down a little bit. Okay? And if your patient's unable to stand, you can try to do them while they're sitting in a wheelchair, as long as it's not one that has the headrest on it, because that will get in the image. So if they're able to transfer over into any other type of chair that still has a back on it, then you can try to do that. If it's just like a rolling chair, I would suggest putting some sort of a padding under their rear end so that they're up a little bit higher, because otherwise sometimes the back of the chair can get caught on the pan machine as it spins around.
Of panoramic anatomy, that will be new. Okay, the positioning errors will be somewhat of repetition, but with some different cases. And then mainly for your reference, I put in some slides about a pathology review. I'll just cover the basics of how we look at images and try to decide what's normal and what's not. Okay. Oh yeah. This usually came after lunch, so I put this in after lunch, but here's something else you have to sit through because I'm in charge. Okay. So I wrote this after a friend broke a tooth, okay. Unlauded loyal worker for my cause, a mournful you and I are put asunder, ever hijacked from these homestead jaws, a lonely cavern now bespeaks the plunder. We as one till confluent demise, from first our efforts joined did I surmise. Adieu, my cracked hydroxy appetite, in pacem requiescat, noble bite. Alas, by croutons were you put to task, forensically with contrite heart I ask. Undone perhaps by Sunday's hefty brunch, the almond's blunt mysticatory crunch, or camouflaged unyielding olive pit in lethal cuspal snare untimely bit. What mutiny, O tooth, O molar mine? Did my demands and yours not well align? If only I had had the slightest hunch, then would that we should still be sharing lunch and savory snacks ad infinitum, given your proclivity to bite 'em. Lamentations are inadequate, and proper eulogies confound my wit. So here's a simple thanks for service true, concerned that in your absence I'll not chew. Your neighbors strong remain to masticate, that hypermasseter I'll castigate, but with the dentate now no longer numbered, I henceforth shall take repast encumbered. Mindful now of wanton reckless chomps, with care I'll manage culinary romps, and moving on a practiced symbiosis chastens maxillary apoptosis. Okay, so on to the good stuff. Keep in mind the geometry of how the images are, the panoramic images are taken. So the sensor, the receptor is on one side, the machine is on the other, and it rotates around. So there's going to be a lot of anatomy that is in the way of the primary image. And that's what we have to try to figure out. Katie mentioned the focal trough. Basically, it's this shaded area, the representation of, that is adjusted according to the machine and according to what we want. And it's that portion of the image that is going to be the most focused. But there's going to be a lot of other anatomy that's in the way. And again, as Katie described, if the incisal edges are properly positioned, so incisal edges with the positioning device here and a ring in the anterior aspect of the mandible, we're going to have a nice image that isn't distorted much. If the teeth and the rest of the jaw is farther from the receptor, so behind the focal trough, there's going to be magnification and distortion. If the teeth are in front of the focal trough, there's going to be, the image will be shrunken and distorted. Ghost images, this is a pan taken of half a cadaver skull. It's a little bit of a gruesome thought, but there is half a cadaver skull here, the soft tissue and the hard tissue, and nothing here. This is all ghosting from this side. So every time we look at a pan, we have to sort through all of this stuff that's in the way, all this noise, if you will. Some basic anatomy review, IAN canal. Again, I'm looking at the opaque lines and thinking floors, walls, or ceilings, just like on a pan. The maxillary sinus is the lucency that I'm outlining here, but there's a lot of stuff in the way that you have to sort through. The line of contrast here, the earlobe, mental foramen. I think there was something else on this one. Not the best example, but I don't know if I put the other slide in. If you look at the anterior mandible in this region here, we have the opacity, which is the shadow of the cervical spine. But then there's also a hint of a lucency through here that has this superior border that looks like a horizontal line of contrast. That lucency is related to the disc space. So we're getting the opacities of the bone of each of the vertebrae here, but also potentially we'll get the lucency of the disc space superimposed. And it can throw off the diagnostics if you don't realize what's happening. Also, sometimes the disc space between C1 and C2 will end up in this region and look kind of peculiar. Epiglottis is here. Thyroid cartilage here. Doesn't always image, but it might, and it can be mistaken for other problems, but that's normal anatomy. The lucent band is the common meatus within the nasal cavity. The lucent band down here is the inferior meatus. And the opacity that I'm tracing out here is the inferior concha. We're looking at it in profile view or sagittal view. Hard palate is actually all of this image from the opacity that is roughly from here up to here. So if you think of the shape of the palatal vault, it's a vault. So while we're imaging it, if the receptor is here, the source is here, and you have this vault in the way, we're going to get a primary image of the bone here and a ghost of the bone here. Primary here, ghost here. Primary here, ghost here. So the image will end up often looking like a series of horizontally oriented parallel opaque lines. I think I will have some other images that are better to show you that. Dorsum of the tongue, I think, which you all would recognize now, is right here. And the lucency is the airspace above the tongue, below the palate. Inferior orbital rim, and again, this is all in your handout, so you can use it as reference. I think on this, what was I trying to show? Some of the overlap. So the red arrow is pointing toward the coronoid process, which is here, but it's also pointing to the soft palate, and the two are superimposed. So that's the superior aspect of soft palate, that's the inferior aspect of soft palate, and it's overlapping the coronoid process. The submandibular fossa, this is an area that the students will often confuse with pathology. So the lucency here, you can see it again here, but it's related to normal anatomy, inferior to the mylohyoid ridge, which, as Jean pointed out earlier during the break, the internal oblique ridge will continue on anteriorly as the mylohyoid ridge. When it becomes the muscle attachment for the mylohyoid muscle, then I would refer to it as the mylohyoid ridge. Anyway, it's the fossa inferior to it. Here you can see it on a coronal view, this indentation of the lingual cortex on a PA. It's that fossa that will image as a generalized lucency. Again, nasal septum, hyoid, hyoid. Zygomatic process of temporal bone is this line of contrast right here. That's the inferior border of it. That, along with the zygoma, make up the zygomatic arch. Here, if we focus on the hard palate, so from this density here all the way down to actually this one right here, this is all hard palate. Primary images and ghost. Also notice this opaque line represents the floor of the nasal cavity, which is the flip side of the top of the palatal vault. Because if you imagine a PA, and if you see the inverted Y configuration on a cuspid premolar image that we'll sometimes see, the inverted Y would have the stem here being the posterior aspect of the nasal cavity floor, this branch of the Y, maxillary sinus floor, this branch of the Y, anterior portion of the nasal cavity. So again, nasal cavity floor and hard palate are all blended in together on the pan. And I think here too you can use this as a reference. So again, notice the ghosting. This is the ghost of the left mandible. That's the main takeaway here. Pterygomaxillary fissure, this region here. For those of you who do injections, this is the target area for a PSA, posterior alveolar nerve block. Maxillary artery and V2 pass through this fissure. Here it is on the skull. The name is easy to remember because this opaque line is the posterior wall of the maxilla. This opaque line is the anterior edge of the pterygoid processus sphenoid bone, so you can make up the name, pterygomaxillary fissure. Okay. So just the basics, hyoid bone is here, inferior cortex is here. Okay, if you look at the inferior cortex, here it looks more opaque, here it looks more opaque, more opaque. It's because it's overlapped with hyoid and spine shadow. Okay, here it looks more lucent because this is the posterior dorsum of the tongue. This is the ghost of the contralateral mandible. So this is left mandible through tongue. This is left mandible through ghost. This is left mandible through neither. So you can break down all the densities based on what the borders are. And I think the rest of the anatomy that we've pretty much covered. Just let me say some quick things. Here's the epiglottis. It's hard to use the pointer here, but there's an image here and then an image there. Two lines of contrast, just separated a little bit. They both represent the posterior pharyngeal wall. The patient was breathing, so that soft tissue was in different positions during the exposure, and that's why we have two images of it. You'll often see two images of the dorsum of the tongue as well, if the tongue was moving. Oh, let's see. Again, you can use this for your reference. Let me point out again, nasal cavity floor is here, this opaque line. It's the flip side of the top of the hard palate, which is imaging all the way up to here. The ghost and the primary images of hard palate, all of these opaque, horizontally oriented parallel lines, if you will. It's all part of the hard palate. Again, for your reference. Positioning errors, to review what Katie went over. Flat occlusal plane means the chin was positioned too high. Chin was up. Chin down, too much of a smile line. Head rotation, you can see magnification on the left side. The ramus is wider. The anterior-posterior dimension of the ramus is wider. Also, the mesiodistal dimension of the molars is wider on the left than on the right. The shadow of the cervical spine we see here. Also notice the lucency, the lucent band here and here. Bordered by the posterior dorsum of the tongue and the inferior aspect of the soft palate. So this is just air in the back of the mouth, the oropharynx basically, superimposed with the mandible. This is mandible through tongue, mandible through soft palate, mandible through neither. Hence the differential in density. So this was a case that a student brought to me and said, what's going on? These are the bite wings of the same patient taken on the same day. The pan shows all of this. Looks like a bridge with no pontics, but maybe crowns that are splinted together. But this is the bite wing from the same day, same patient. No bridge. So what's going on? Well, in evaluating this pan, there are a number of errors. The chin was up too high. The head was rotated. Look at the magnification of the mesiodistal dimension here compared to here. So the head was rotated, chin was up, and we have ghosting of this metal this metal and the metal in the chamber of the root canal treated tooth that is shifted up and superimposed with the crowns on the maxillary left. So the errors here were all related to patient positioning, and it created this non-diagnostic pan. So the patient was exposed for nothing, really. We had to retake it. Katie, was this yours? I think this was Katie's, yeah. So, first pan, what's all that about? Second pan, it's not there. Well, what happened here? I can't see from where I am. There was enough rotation or tipping of the head that all of this metal was ghosted up here. Okay, so positioning is very important. Again, mainly for your reference, but I want to go over a couple main points here. When we do interpretations of images, we look at certain radiographic features and then try to put those features together with the clinical findings to create a differential diagnosis. The main features that we're looking at: location, shape, size, number, internal content, border, periphery, density, and the pattern of the density, and the effect on adjacent structures. If you consider these 8 concerns, it will help you a long way to creating a differential diagnosis. So I'm looking at this pan, and we'll just focus right here. I see a lucency that is circular to oval in shape. It's homogeneously lucent, not much of a pattern within it. The borders are smooth, they're regular, and they're corticated. There's an opaque line around them. That means it's walled off. It's superimposed with the roots of 18 and 19, and it appears to be having an epicenter at the distal root of 19. So the location relative to 19, and then given the clinical findings of the crown of 19, suggests that it's coming from 19. And the density, the shape, the smooth corticated border suggests a cyst. And so at the top of the differential then would be radicular cyst, secondary to pulpal disease. But again, those features are what help us lead us to a differential diagnosis. So radicular cyst, we have 2 of them shown here. Notice this one has a cortex. The border is corticated. There's an opaque line here. This one, not so much. Because there's no border, or because the border is not corticated, it suggests that this one is infected. This one, probably not. There are a couple that I want to spend some time on. The other ones, again, you can use for your reference if you're interested. Bone's response to inflammation will sometimes involve an increase in osteoclastic activity. The bone will be destroyed and rarefied, and the image will be more lucent. Other times, osteoblastic activity will be stimulated, and the bone will become more dense. Here we have a situation of both. There's a rarefying osteitis adjacent to the apex, and then beyond that is a sclerosing osteitis. All responses to inflammation. We're looking at reactive bone. In addition to the density changes, so rarefying osteitis, sclerosing osteitis, look at the pattern. Here I'm seeing more or less normal trabecular pattern, but here, where I'm approaching the area inferior to the mylohyoid ridge, there's an increased density and a much tighter trabecular pattern when there should be less density and less pattern. So this is all reactive bone down here. It's not normal bone.
Okay, this is more normal bone, inferior to the mylohyoid ridge. We can pass through some of these. And I wanted to spend some time on periapical osseous dysplasia. Because there are 3 stages to this condition. So periapical osseous dysplasia, location, apical to roots. The 3 stages, early, middle, and late, present differently radiographically. Early on, the images will be lucent. Later on, mixed density. The final stages, more opaque. The early stage can very easily be confused with, for example, a radicular cyst. So on first glance, apical lucencies, if you jump immediately to a diagnosis of radicular cyst, in this particular instance, the diagnosis would be wrong. There are a couple clues radiographically. The PDLs are intact around all of these teeth. This one didn't reproduce very well, but the PDLs are intact. If this were a radicular cyst, the PDL space should be widened. Also clinically, these teeth respond normally. They remain vital. Okay, later stage, what started out as a lucency becomes more mixed in density. Okay, this is earlier, this is more middle stage, mixed density, but the teeth always remain vital. Very easy to misdiagnose this if you don't put it in your differential. Okay, so early stage, periapical osseous dysplasia, later stage. Asymptomatic, teeth remain vital. Hopefully it's less common, but we do see instances where these teeth are diagnosed in the early stage and treated endodontically or removed, and they don't have to be treated at all. Some other images. Florid osseous dysplasia, same condition, just occurring in multiple quadrants. But see, those look kind of scary, those apical lucencies. But they turned out to be dysplastic bone, not inflammatory lesions. Oh yes, and so this is the standard pan. This is a pan reconstruction from a CBCT, and you notice there's no ghosting. There's a lot less stuff in the way when we're looking at a panoramic reconstruction from cone beam data than when we're looking at a standard pan. It helps. Okay, so let's go through this slide also. This is one of the images we just saw. But pulling together some of the things we've gone over already, if I see this image, in my differential, so I'm looking at the lucency here. I'm going to consider anatomy because we're in the mandibular anterior, the mental fossa is here, and it will image as a lucency, superimposed with the roots of the anterior teeth. Early stage POD would be in the differential also because of the shape. See, it's not a regular oval shape, which would be the typical shape of the mental fossa. Because the PDLs are intact and the lamina duras are intact too, at least where they're not burned out, I would put pulpal disease at the bottom of the differential. So this is how I'm using the radiographic features to try to narrow down the differential diagnosis. If we're looking at the opacity here, location, midline mandible. Right off the top, I'm going to think genial tubercle. That's normal anatomy. Osteosclerosis, increased density in bone, that can look like this too. But what would the cause be? Well, there may not be a cause for an osteosclerosis, but still, because we're in the midline, it's probably anatomy. Could it be a sclerosing osteitis, which can look like a sclerosis, but if you see itis, it implies inflammation. There's a an inflammatory source. And I don't see any potential inflammatory source down here. So again, location, density, the shape of things, they all influence how we get to a diagnosis. And again, this can be just for your reference. If anybody's interested, I'll be happy to spend more time with this one-on-one, so don't hesitate. Let me go through a little bit of this one. So we're looking at this lucency here on a pan. It's a section from a pan. So remember we talked about the submandibular fossa, which is in this region, but the shape is wrong. Okay, and the location is extending beyond where the mylohyoid ridge would be, so up here. And then the mylohyoid ridge continues on anteriorly, and this border I can't describe as anything normal anatomy. So the shape isn't right, even though the density might be. Also, there's a smooth border. It's corticated. There's a wall around it, basically. It's quite large, but if you look at the axial view, it's not expanding. It's not expanding. So that, if we look at potential diagnoses here, if we consider malignancy, because it is lucent, you should consider malignancy, but it has regular defined borders that are corticated. A malignancy grows very rapidly, and generally, not always, but generally the borders will be very fuzzy, not defined, and the lesion is growing so fast that the body is not able to keep a wall intact. So you wouldn't see a cortex. So malignancy drops in the differential. Ameloblastomas, if this were a unilocular ameloblastoma, it might look like this on a pan with a smooth corticated border, but they expand a lot, and the inferior cortex is not expanding. In cross-section, the buccal and lingual cortices are not expanding either. So ameloblastoma drops in the differential. A radicular cyst, well, I don't really see a cause. There's a filling here, but not too big. Maybe there was trauma, but I don't see any evidence of it. So idiopathic bone cavity is what this happens to be. That's not the important thing right here, but malignancies would expand, they would perforate the cortex, not expand it, but just blast right through it. They would not have a defined border generally and would not be corticated. Okay, so again, using those radiographic features can help narrow a differential diagnosis. So let's go past these. Again, if there's individual interest, come to me. Okay, but we want to get you upstairs so we can start working on technique. That's the main thing. Anytime you see an unerupted tooth, consider dentigerous cyst. Look at the follicle, the follicular space. If the size is beyond, so if the distance from the enamel of the unerupted crown to the wall of the follicle is more than 3-4 millimeters, then we want to consider it dentigerous cyst. They expand a lot. You can see it pushing the crestal bone up here, displacing teeth, resorbing roots, all of those things. Again, just more conditions you can review on your own. All right. Let me show you this slide. So here we have a section of a pan. This bone does not look normal. Something is loosened here that shouldn't be loosened. There's no border here that is normal anatomy. Not normal anatomy. Okay? It's hard to see where the edge is right here. Maybe there's an edge here, but where's the edge here? It's certainly not corticated. If we look at an axial view, Here's the original contour of the lingual cortex. Here's the original contour of the buccal cortex. Compare it to the unaffected side. This cortex isn't expanded, it's just perforated. If this were a slow-growing lesion, it would grow slowly enough that the bone would just expand with it and balloon out. I'm not seeing that here. I'm just seeing a perforation. If this had been expanded bone, it would have been out here like this for a lesion that's that large. On the coronal view, same thing. Here's the unaffected side. This is the medial aspect of the ramus. This is lateral, so that's buccal, that's lingual. The alveolar process is in here. See this contour and this contour? It's essentially unaffected in terms of its position, but the bone is completely gone. It's been perforated by the malignancy. Okay, so perforation, not expansion, that's a sign of malignancy. These didn't reproduce very well, but I would like to spend a moment on this slide. Here we're looking at periodontal disease, here at a malignancy. Periodontal disease could present like this, but let's break it down and look at the specific radiographic features now. There's an increased lucency here, but I can still see an edge of one aspect of the bone, and I can see a kind of an edge here. Same thing here. There's an edge there. Even though it's not well defined, there's an edge there. And then adjacent to it, the bone is a little bit more dense, but then after a few millimeters, we get back into normal density and pattern of the bone. That suggests that this is a chronic, slowly progressing process. The body is able to keep a wall or an edge of bone intact, and it's sclerosing adjacent to that edge to protect it, to protect the normal bone. If you look over here, there's no edge at all. It's very, very fuzzy, certainly no cortication. And beyond it, there's no evidence of normal trabecular bone. So there's a very wide transition zone that suggests that whatever this is, it's invading the bone. Also, if we extrapolate, it looks like the bone levels are about normal over here. We can't see it, but there's bone here. I can tell because of the pattern. It's only this one tooth that is affected. Periodontal disease rarely affects just one tooth. So those are the clues that this is a malignancy. It turned out to be a squamous cell carcinoma, originating in the soft tissue and invading the bone. Okay. Questions about that basic review or not?